Welcome to the HITLAB webinar, Preparing for the Surge. Tonight we have with us a phenomenal panel to help us through some of the strategies, medical technology and orientation around the surge and preparing for the surge. With us to start, since he has to run, since he's in the middle of preparing for the surge and actually in the middle of the surge itself in New York City, is the Chief Information Officer of York-Presbyterian. Again, Daniel, thank you for joining us today.
Well, thank you, Stan. Thank you for having me on. If you don't mind, I'll just give a couple of opening comments about the situation as we find it right now and share a couple of the insights about what we're doing to react to the situation we have and prepare for what's going to be an even worse situation coming up. New York-Presbyterian has 11 campuses across the New York metro area. We're in Queens, we're in Brooklyn, Manhattan, Westchester. And so we're seeing this on all sides. I think as of yesterday, there were roughly 18,000 COVID positive patients in the New York metro area, and the number is still increasing rapidly. When you are a leader in a health system like this, our CEO and COO have us focused on providing outstanding care. At the same time, we're trying to prepare for everybody who's coming in the door. We're thinking about novel ways to approach this. This is a novel virus, so we have no experience with it whatsoever. And so we're learning from China, from Italy experiences. And I got to say that the physicians and nurses of our health system are doing a fantastic job responding in every way, delivering outstanding care. And yet the volume of patients is significant. And so it makes us think differently about what we're doing. We're using video technology, remote work, remote access, and remote diagnostics in ways that we had planned on doing, in fact, had underway in many ways, but this is accelerated it tenfold. I'll give you an example. 3 weeks ago, we were doing an average of 100 to 150 video visits a day. Now we're doing well over 2,000. We've ramped up from about 1% of all of our patient interactions being via video. Now we're at 25% or greater. We're making sure that we're serving our patients, those that are not COVID positive, by going to them in their homes using video. We're also trying to keep patients out of our hospital to keep everybody safe. So it's a challenging environment, but it's through a lot of coordination, rapid adoption of technology, and the flexibility of our clinical and operational leaders that we're getting it done. Well, first of all, I'd say I think our government leaders are doing a good job in thinking about how to lessen the impact and flatten the curve by keeping people safer out of the hospitals and trying to increase social distancing. So the more we can do that, the better we're going to be off, and it's not going to get to the second, third, fourth tier cities as it moves west and south. So I hope that no other cities have the impact that Seattle, that area, New York and Los Angeles have had already. Right now, we have the clinical leaders of Columbia University Medical Center and Columbia doctors working together to put patients on dual split vents. And so ventilators are a limiting factor in a virus like this, which has significant respiratory impact. And so to avoid the point of getting to a point where we don't have enough ventilators, we have to maximize those that we do. And one of the novel ways of doing so is finding patients that are roughly similar from a clinical perspective and literally from a physiology perspective, height, weight, body mass, volume of breathing, and then aligning them and putting them on a ventilator together. The ventilator can more than handle it. It's a question of managing the settings so it meets both of their needs. And so that we just started that a couple of days ago. We've had some success already. Our clinical leaders are sharing that information about what we're learning with other leaders around the city and around the country. So split vents is one area. Another area I'm really proud of is the way that we've turned our ORs into ICUs. So we made the decision about a week ago to stop all elective procedures. So we're doing very, very few surgeries. Certainly trauma and life-saving surgery that has to happen, we continue to do that. But we've decreased by a significant percentage the number of surgeries that we're doing. So we have entire ORs that are empty, starting at Columbia University Medical Center, moving to Weill Cornell Medical Center, at Lower Manhattan Hospital, the Allen Hospital, and New York-Presbyterian Lawrence Hospital. we're taking our ORs and converting them into ICUs. So anywhere from 2 to 4 beds in a OR is becoming an ICU. We're moving the beds in where there was just one table for patients before. We'll put 4 beds. We're connecting gases. We're splitting gases. We're moving physiological monitoring equipment in. We're moving extra ventilators in. We're connecting them with their technology. Many of you who work in electronic medical records might be fascinated that we're creating temporary beds in the EMR so that there's a place to admit the patients so that they're in temporary bed 309 and that we can place orders and get results on them. So turning ORs into ICUs is something that I never thought would see happen. And yet we've created probably more than 50 or 60 bed capacity just in the past couple of days doing so, and we'll keep doing even more of it. Well, great question. First of all, I'd say it's never too late. I'm amazed when there is a crisis at hand, what you can get done. We have great ideas at 3:30 in the afternoon that get developed and implemented by 11 o'clock at night. So we're working at that speed right now. Our digital transformation has accelerated, 6, 9, 12 months in just the past 2 weeks based on what we're doing. There is the need for a foundation. You can't create this stuff out of thin air. And I'll give you an example on the triaging. We were already doing a lot of digital medicine. We were doing on the order of about 500,000 video patient encounters every year, even before this crisis hit. And not every one of those was Dr. Smith in his office with Mrs. Jones at home and having that video interaction. That was certainly some of it. But a lot of our video interactions were a pharmacist sitting in the pharmacy doing the med rec for a patient up on the floor via video, or medical screening exams. And this is the example that I'll use to talk about triage. We were having physicians who were sitting in an office somewhere, actually seeing many patients coming through our emergency departments and having the interaction with the patient via video, doing the quick medical screening, deciding what needed to happen next and sending them on.
All right, so we're going to go and just walk through some introductions to the other 2 participants in the panel tonight about preparing for the surge. First is Dr. Jon Cohen. He is the Chief Executive Officer of Bioreference Laboratory, 3rd largest laboratory in America, the primary laboratory for meeting most of the testing demand that's happening, particularly in the New York metropolitan area, but around the country. And then also with us is Dr. Marco Costa, who's the president of the University Hospitals Western Region Hospital System.
Right now, as this literally is changing still more than every day, I would say almost every several hours. Just to give you a high level, so we became clear that when the CDC launched their quote assay and actually published the sequence for the virus, a bunch of people began to look at it, but it wasn't until they actually released they gave the permission for commercial laboratories to begin to develop tests around their recipe that things began to move. It was also clear very early on, that was around the weekend of February 29th, it was also clear for anybody who was going to bring up the CDC assay that it was relatively slow. When you get the virus off of a swab, you have to extract it, which is a very manual process for the CDC assay. You plate it, and then you put it onto you extract it, and then you put it onto another analyzer. The other problem was they only run 40 to 60 tests at a time. So at most, if you're running 24/7, you can run about 100 to 150 of the CDC. That was obviously not going to be a solution. We at the time made the decision to bring up multiple assays at the same time on different, I'll call them platforms, think of them as analyzers or machines. So as we moved through bringing them up, we began to get to a higher number of throughput. We started off with a couple thousand, we moved to 5,000, we moved to 10. And as of today, we're upwards of 20,000 tests a day. We are prioritizing testing relative to hospital inpatients so that the physicians, nurses, medical staff on the front lines can get results as soon as possible. Our turnaround time is basically 24 to 48 hours. For in-hospital ICU, it's about 12 to 24. That's one group. The second group is people who are symptomatic, who are going to their wherever, doctors, ERs, wherever. And the third way of accessing the system right now has been these drive-throughs. The drive-throughs have been very successful, started in Korea, first, then in Washington State, and then we actually were the first ones to set it up on the East Coast in the partnership with New York State. So we're running 20 plus drive-throughs now around the country. So if you look at how you access COVID testing right now is basically through your physician or medical group, possibly. Second, through drive-throughs, and third, through hospital criticals.
Thank you for allowing us to participate in this exchange of knowledge. We are in the state one, what we call conventional state of readiness, and we continue to move. Yes, in that image there, you show some of our continuum of preparedness. So we are lucky to be a little bit remote from the hot zones, and we have this opportunity to prepare for both the conventional, the contingency, and the crisis. Yes, I think I would like just to mention that while we focus on readiness for addressing the problem of COVID, one area that it's very important for us healthcare executives is how we conduct our normal business and how we serve our community, who are continue to have chronic diseases and continue to need the support of the healthcare. So we create thresholds so as we can achieve a level of readiness. Then we go through, we have the incident command structure that's already functioning over the past 2 weeks. Every day we advance, it gets more aligned and coordinated. And then we have a day-to-day business that we have to manage as healthcare. So one area that probably most 90% of healthcare system across the country is facing is how do you flex and how you control your expenses. And today we are discussing more about what is essential and what is non-essential. When we reach the tier 2 level, which we are not there yet in Ohio, we are preparing ourselves to be ready. We have 12 hospital systems. We have the ability here because we have an integrated intensive care unit, and we have an integrated ECMO system that we have already prepared in the phase 1 to answer the demand that might surge in specific locations. As you know, in New York, there are specific hotspots within that region that might be a bigger challenge for us because we cover more than 92 miles of geographical area. So we have to prepare in a way that we can attack immediately with our teams. So we're creating teams that can be rapid response teams that can go to those places and release the local teams over the next 4 to 24 hours to make sure that we provide that surge capacity for tier 2 level, which is what we're doing right now. And tier 3 level is when the crisis really hits, and then a lot of this rapid response discharge will be all over the health system. We are preparing our teams to do that. We have those plans already for each hospital as well as for the health system, at this moment.
I would say that the next big leap will be a serology test, which will test for whether or not patients have antibodies to the disease. That will change that'll change the paradigm sometime a month or 2 months down the road, because it's essentially a plasma-based blood draw where you can determine whether a patient is immune or not based on their IgG levels. It's a very different, just to remind everybody, the COVID-19 test, essentially what it does is a PCR test. It tells you whether or not you have an active viral infection. A serological test is very different. It tells you whether or not you've had the disease and essentially probably have enough antibodies that you're immune. So that's a big change that will occur. We think will occur in the next month to 2, but it's not available right now. That's the big issue going forward.
Wow, that is an impossible prediction to make. We are focused so much in taking care of the COVID world right now that I didn't spend much time of thinking what it's going to be afterwards. What we know is going to be different. We know that our social interactions will be impacted at the personal level and at the professional level. What we know is the respect that we're going to have for diseases and for each other will change. And we as health systems, we have learned how to operate in a much better way. So there are things that are coming from this that's going to be incredibly positive. Our teams, our administrators, our nurses, our staff, our ADs, all of us have come together. We have done a survey just this week about skills, different skills that everybody can contribute. And we have had a massive response and many individuals who offer to serve in any different capacity to help our population. So those responses we have not seen yet before in the United States in a magnitude that we are seeing today. This is not a one-day crisis. It's a long journey. It's going to take a little while for us to even understand what is going to define post-COVID crisis, what is the time frame. And I think what we need to do now is to focus on today, on the moving present, and how can we do the best we can as a society, as individuals, and also in our case as health systems to make sure we protect our patients and our employees, because we are critical in this phase to address this crisis.
That's fantastic. Well, thank you, Dr. Costa. Thank you, Dr. Cohen, for joining us. Thank you for all of our attendees for joining in as well. And everyone, please stay safe, stay well, and we'll see you next week here at HITLAB. Take care.
Take care. Thank you.
Thank you.